Hello, my dear students. Welcome. Welcome to psychiatry. We are going to do the complex subject of psychiatry in different modules and different presentations. And we're starting with the first module today on this presentation. And this presentation is going to be about the introduction to psychiatry, the genetics, the anatomy, and the biochemistry involved in psychiatry. We start with the classification systems of the psychiatric disorders. What is the way, what is the basis to classify the various psychiatric disorders? There are two important methods of classifying the psychiatric disorders. The first one is called DSM and the second one is called ICD-10. What's DSM? DSM is Diagnostic and Statistical Manual. Diagnostic and Statistical Manual. That's called DSM. And the second one is ICD-10. That's the International Classification of Diseases, 10th edition. What's Diagnostic and Statistical Manual of Mental Disorders, which is abbreviated as DSM, given by American Psychiatric Association? The DSM-1 edition came in 1952, the second one came in 1972, the third one came in 1980 and it was revised in 1987. The DSM-4 came in 1994 and it was revised in the year 2000, and the DSM-5 is expected in May 2013. ICD-10, the International Classification of Diseases, 10th edition, is the classification of mental and behavioral disorders given by World Health Organization in Geneva in 1992. DSM, or the Diagnostic and Statistical Manual, considers 5 different axes and it's called multi-axial diagnosis. Look at the table. The axis 1 describes the clinical mental or psychiatric disorder. For example, patient suffers from schizophrenic disorder. Axis 2 is restricted only if the patient has a personality disorder or has mental retardation. Now for this patient, in this example, the patient neither suffers from personality disorder nor the patient has mental retardation, so no diagnosis against axis 2. Axis 3 describes the general medical conditions. For example, for this patient there is influenza. Axis 4 describes the psychosocial and environmental issues in this patient. For example, here I have written victim of child neglect will be mentioned in front of axis 4. And the last one, axis 5, is the GAF, or Global Assessment Functioning. That's the level of functioning and emotional symptoms. And the superior functioning has to have the score of 100. Now for this patient, for example, arbitrarily I have written the Global Assessment Functioning score is 44. So for this patient, if I want to give a multiaxial diagnosis, I'll say that the patient has schizophrenic disorder, no diagnosis as far as personality disorder and mental retardation is concerned. Patient suffers from influenza, is a victim of child neglect, and his global assessment functioning score is 44. This is how you give a multiaxial diagnosis. ICD-10 is multiaxial presentation as well, but there are 3 axes. The first axis describes the clinical disorder, the mental as well as physical. The second axis here describes the disabilities which are resulting from mental and physical disorders. And the axis 3 is the contextual factors like social environmental factors, housing, economic situation, education, literacy level and legal factors, if there are any family histories, lifestyles, childhood events, so on and so forth. So all those environmental and other factors, contextual factors, come under axis 3 in the multi-axial presentation. We go on to discuss some genetic factors related to psychiatry. Family risk studies are important, twin studies are important, and the concordance rates for various disorders have been already known. For example, let's have a look for schizophrenia and bipolar disorder. For schizophrenia, in a first degree relative, the concordance rate is 10%, whereas for bipolar disorder, it's 20%. If there are 2 parents suffering with the same disorder, then for schizophrenia, the concordance rate is 40%. And bipolar it is higher, it's 60%. And if a monozygotic twin is suffering from the disorder, then the monozygotic twin of this particular patient is likely to have 50% concordance rate, and for bipolar it's 75%. Let's come to some other disorders in which genetics is important. Number 1 is Alzheimer's disease. 25 to 50% of the close relatives develop Alzheimer's disease. And the rate is more in the monozygotic twins as compared to the dizygotic twins. Chromosome 19 has been implicated in Alzheimer's disease, and the presence of apolipoprotein E4 allele poses higher risk. Apolipoprotein E2 allele produces less risk of having Alzheimer's disease. And patients with Down syndrome, if at all they live beyond the age of 40 years, then they have a risk of developing Alzheimer's disease. The next important illness is Huntington. There's an abnormal gene on the short end of the chromosome 4, which has been demonstrated as far as Huntington is concerned. And if there is one parent affected, then there is 50% chance of getting Huntington. As far as Tourette syndrome is concerned, monozygotic twins have higher concordance rate as compared to the dizygotic twins. And very interestingly, substance abuse or alcoholism is associated with more chances of getting substance abuse in the biological children of the patient who is already suffering from substance abuse. So that's regarding some important genetic factor issues in psychiatry. After genetic factors, we move on to the anatomical important issues in psychiatry. For example, prefrontal lobe syndrome or the frontal release signs, they include perseveration. What's perseveration? Perseveration is repetition. Repetition of the meaningless words, acts, behaviors, constructions, etc. Then a very important frontal release sign is disinhibition. Then you have sudden outbursts of temper and regression to infantile reflexes. These are some important frontal release signs. Frontal cortex, when you get lesion on the frontal cortex, on the left side of the frontal cortex, it usually manifests into depression, into the depressed mood. And the lesions of the right frontal cortex usually amount to the elevated mood in the patient. As far as basal ganglia is concerned, the important diseases related to the basal ganglia are Parkinson disease, Huntington chorea, Tourette syndrome, Wilson disease, and the last one is Farr disease, in which there is calcification. Temporal lobe, important signs of temporal lobe lesions are deafness, receptive aphasia, amnesia, where there is short-term and long-term memory loss, there are personality changes, and there are emotional disturbances. Coming to the limbic lobes, as far as hippocampus is concerned, the important disease is Alzheimer, to remember, and hippocampus is concerned with memory storage. And in Alzheimer, usually we get the affection of the new learning and the short-term memory. So the new learning and the short-term memory gets affected. Amygdala leads to the disease called Kluver-Bucy syndrome. The lesions of amygdala lead to Kluver-Bucy syndrome, and amygdala is concerned with the coordinating of emotions with the somatic responses like anger, aggression, etc. Next we go to the occipital cortex. Visual inputs and recall is the function of occipital cortex, and the occipital cortex affection leads to cortical blindness and leads to homonymous hemianopia, that's contralateral visual loss. As far as the parietal lobe is concerned, the non-dominant parietal lobe is concerned, a very typical feature observed in the patients is called constructional apraxia. The patient has difficulty outlining the objects. Have a look at the slide. If I have given this construction to the patient, which is writing as original, this is the original construction, and the patient is asked to copy the construction, you can look at what patient has done. Patient has tried to complete this particular diagram, this particular figure, but the patient could not complete because there's problem, difficulty outlining the object, so the outline is not complete. This is a very silent feature of constructional apraxia found in non-dominant parietal lobe lesion. This second one also, as far as the non-dominant parietal lobe is concerned, and you can have a look at this slide, it's called hemi-neglect or hemi-inattention. Hemi is one side. So the person's brain, the person's mind neglects one side. So there's hemi-neglect or hemi-inattention. Have a look at the picture. The original picture was a circle, a diagram like a circle in which there are two lines, and look at what construction the patient has done. Patient has incomplete outline of the diagram because of the previous one which we saw constructional apraxia, plus there is hemi-neglect. The person has not drawn the second line which is supposed to be on the right side, and the constructional apraxia is also very obvious because the patient is not able to visualize the right, not able to understand the right side. So that's called hemi-neglect or hemi-inattention. So these are two typical features of the non-dominant parietal lobe lesions. We now come to dementias. What are the two important types of dementias? One is Alzheimer's dementia. You must remember from your multiple choice question point of view, you may be asked about this. In Alzheimer's dementia, there is progressive onset of dementia. And in vascular dementia, there's quick onset, especially in the multi-infarct type, where you get cerebrovascular accidents, there may be patchy deterioration. And because it's vascular dementia, obviously there has to be one more organic or medical condition, the cause, like hypertension or diabetes. There are some other reasons of dementia. They include, have a look at the slide, Pick disease, Creutzfeldt-Jakob disease, Wilson disease, that's hepatolenticular degeneration, then Huntington, Parkinson, and Gerstmann syndrome. So as far as dementia is concerned, important to remember vascular dementia, quick onset and maybe patchy deterioration, and in Alzheimer dementia, it's progressive onset. Now we come to some important psychiatric illnesses, which are commonly called psychosis and neurosis. You can have a look at the picture and you can see diagonally I have shown psychosis and neurosis. What's the great difference in psychosis and neurosis? In psychosis, there's loss of ground reality testing. So I've written on the slide, reality is lost and it's a thought disorder. So it's called psychosis. Whereas if you come to neurosis, the reality is totally intact and the person is not getting delusions, hallucinations, illusions, kind of psychotic symptoms. So in neurosis, reality is intact. In psychosis, reality is lost. The two other diseases which are shown on other diagonal is the mood disorders. Number one is depression, and in depression you have a low mood. Low mood is called as depression. The other one is called unstable mood, and sometimes the patient has got a high mood and sometimes the patient is in low mood. Because there are two poles of this disease, it's called bipolar disorder. We need to know about psychosis, neurosis, depression and bipolar disorder, the important psychiatric illnesses. Let's move on to the next slide. What are the neurotransmitters involved? In psychosis or schizophrenia, there is increased levels of amines, and these amines are DA, that stands for dopamine, NE, norepinephrine, and 5-HT is 5-hydroxytryptamine or serotonin. Whereas if you come to the depressive disorders, that's the major depressive disorder or the mental depression, you have decreased amines. The levels of amines in the brain are decreased, and the most important amines involved here is norepinephrine and 5-HT. Their levels go down. So that's the major difference as far as the biochemistry is concerned. And as we had said, we are going to discuss the genetics, anatomy, and we have entered the biochemistry of behavior. So as far as the neurotransmitters are concerned, psychosis is supposed to be increased level of amines and depressive disorder is supposed to be the decreased levels of amines. Let's discuss some important neurotransmitters. The first one is dopamine. And there are three important pathways which I want to tell you. Number one is nigrostriatal pathway, in which if there is less dopamine, we usually get the involuntary movements, and that's the extrapyramidal effects. For example, Parkinson disease. The next row is telling you about mesolimbic cortical pathway, and just now we saw if there's increased level of amines, that's excess dopamine, for example, leads to psychosis, and this is typically called positive symptoms in schizophrenia. The third important pathway involved with dopamine is tubuloinfundibular pathway, and in this pathway, if there is less dopamine, it's as good as less PIF. What's PIF? It's prolactin inhibitory factor. Dopamine is same as the prolactin inhibitory factor in the tubuloinfundibular pathway. So if you get less dopamine, or for that matter less PIF, it leads to inhibition of prolactin inhibitory factor. Less DA means less PIF. So it's inhibition of inhibition. It leads to hyperprolactinemia. So these three are important issues as far as dopamine is concerned. The next very important neurotransmitter in psychiatry is 5-hydroxytryptamine. And 5-hydroxytryptamine is concerned with mood, sleep, pain, appetite, sexuality, and very important, impulse control. If there's increased 5-hydroxytryptamine, it leads to improved mood and improved sleep. It leads to delayed orgasm and can lead to psychotic symptoms. There is another illness called carcinoid tumor. In the carcinoid tumor, you have increased levels of 5-hydroxytryptamine, and you can assess this by measuring the levels of 5-HIAA, which is 5-hydroxyindole acetic acid, is a metabolite of 5-HT. Carcinoid tumor secretes 5-hydroxytryptamine and you get more levels of 5-HIAA. Whereas if 5-hydroxytryptamine is less, is going to be a disaster, is going to lead to very severe depression of the mood. Please remember this, and this is a very high yield issue as far as your multiple choice questions, as far as all your examinations are concerned. Less 5-HT is depression of the mood and leading to very serious poor impulse control. This patient becomes impulsive, and naturally the patient is likely to go for violent behavior, as well as this patient is likely to go for suicide. Those patients suffering from major depressive disorder who went for suicide and committed successful suicide, when the autopsies were performed, they were found to have extremely low levels of 5-hydroxytryptamine in their brain. So I hope you are going to remember decreased 5-HT means mood depression, and I would like you to come to the thread that whatever drugs are used as antidepressant drugs, they are going to concentrate, they are going to potentiate, they are going to increase the 5-hydroxytryptamine, because in depression the 5-hydroxytryptamine is less. Let's go to the next neurotransmitter, that's histamine. Is it important in psychiatry? Yes, it's important for another reason, is there are many antipsychotic drugs and many antidepressant drugs have got an additional effect of blocking H1 receptors in the brain, H1 blockade. So because these drugs are blocking the H1 receptors, it leads to more sleep, it leads to more appetite. Because the appetite of the patient increases, the patient starts eating more, and gradually there's a weight gain. So when you go on reading the psychiatric drugs, you will realize that at many places it's written that this weight gain due to this drug. What's the reason? Because the drug is blocking the H1 receptors, and blockade of H1 receptors leads to increased appetite, the patient eats more and leads to weight gain. So I have given a red color to this so that you would remember whenever you listen to a drug in psychiatry and you talk about the weight gain, it's most importantly, most appropriately the H1 blockade by this drug which is responsible. We go on to know some metabolites. Norepinephrine has got two important metabolites. The first one is MHPG, that's 3-methoxy-4-hydroxyphenyl glycol. And the second important metabolite, I hope you know this, that's vanillyl mandelic acid, or VMA. As far as dopamine is concerned, important metabolite is HVA, or homovanillic acid. And just now I referred to the metabolite of 5-HT, that's 5-HIAA, 5-hydroxyindole acetic acid. When the patient has depression, usually we have already said that the levels of amines are less. So there's decreased norepinephrine, there's decreased 5-HT, there's decreased dopamine, and in the bracket on this particular slide, have a look at the slide, I have shown the metabolite of this particular neurotransmitter. For norepinephrine, there will be less MHPG, for 5-HT there will be less 5-HIAA, and as far as dopamine is concerned, there will be less homovanillic acid, that's HVA. When the patient suffers from mania, usually there's increased levels of amines, most importantly dopamine. So naturally this patient is likely to also have increased levels of homovanillic acid. As far as psychosis is concerned, we already said there's increased levels of amines. So dopamine, 5-HT and glutamate are likely to be increased. We move on to the next slide to look at anxiety and dementia. In anxiety, there's decreased GABA, that's gamma aminobutyric acid, and also decrease in the 5-HT, that's 5-HIAA, and there's increased norepinephrine levels, so MHPG levels will be high. Just wait here for 1 second. Look at this once again. Anxiety and decreased 5-HT, anxiety, decreased 5-HT, decreased 5-hydroxytryptamine. And if you look at the drugs which are called as selective serotonin reuptake inhibitors, which concentrate or which potentiate 5-hydroxytryptamine, they are extremely useful in many anxiety disorders. Basically, these drugs are antidepressant drugs. The selective serotonin reuptake inhibitors, or SSRI, are basically antidepressants, but they are extremely useful in various anxiety states. The reason is here because in anxiety there is decreased 5-HT. You can give an SSRI and you can increase the level of 5-hydroxytryptamine. I hope you enjoyed this. Then in dementia, as you know, there is decreased acetylcholine and there is increased glutamate. So that's about dementia. Now let's go on to classify the various psychiatric disorders. This is a module on introduction to psychiatry. So let's know at bird's view what are the various psychiatric disorders which we are going to discuss on the subsequent presentations. The psychotic disorder which have the characteristic of psychosis, that's loss of ground reality. We have two important diseases, schizophrenia and delusional disorder. The second row on this table is showing you what is called mood disorders. Another English word for mood is affect. So mood disorders are called affective disorders, and they include major depressive disorder, that's your depression. Then bipolar disorder in which there is unstable mood, and 2 more disorders, cyclothymia and dysthymia. So mood disorders or affective disorders include major depressive disorder, bipolar disorder, cyclothymia or dysthymia. The next one is non-psychotic disorders, and I'm specifying non-psychotic means there is no psychotic symptoms. When I speak of psychotic symptoms, I mean to say the ground reality is lost. When I say ground reality is lost, what I mean to say is the thought is in problem and the patient is likely to get delusions, the patient is likely to get hallucinations. When this does not happen, I am calling it non-psychotic. So non-psychotic disorders in which reality is intact is neurosis, and the neurosis includes 3 various disorders. Number 1 is anxiety disorders, number 2 is eating disorders, and last one is somatoform disorders. As far as anxiety disorders are concerned, there are various disorders which come under this category. Number 1, generalized anxiety disorder. Number 2, panic disorders. 3, phobic disorders. Number 4, obsessive compulsive disorder, OCD, obsessive compulsive disorder. And the last one is post-traumatic stress disorder. I would like to tell you that this obsessive compulsive disorder and post-traumatic stress disorder, PTSD, are very often asked on the examinations, especially the multiple choice type of examinations. So please pay attention to the anxiety disorders, and I would like to highlight, just now a few minutes ago I said that in anxiety disorders also 5-HT is less. So those drugs which concentrate 5-HT, that's SSRI, selective serotonin reuptake inhibitors, which are supposed to be basically antidepressant drugs, are also useful in anxiety disorders. Anyone ask you other uses of SSRI is going to be anxiety disorders, and you can close your eyes and say generalized anxiety disorders, panic disorders, phobic disorders, obsessive compulsive disorder, and post-traumatic stress disorder, PTSD, you are going to be right. So that's about the non-psychotic or neurotic disorders. We go on to the next slide to complete the classification. Personality disorders. There are 3 major types of disorders. Odd and eccentric personality, number 1. Anxious and fearful personality, that's 2. And dramatic and emotional personality, that's number 3. So these are 3 important personality disorders. Next, organic mental disorders include dementia, and the last one is substance use disorders. These are intoxication and psychosis, dependence on a particular substance, and the withdrawal state, withdrawing from a particular substance. So this is to complete the classification. When we went through all this, I am sure you felt everything is interesting. Everything is extremely interesting to know and to understand. At the same time, I would like to remind you that you are dealing with a patient. You are not dealing with a story. So you may feel it is interesting, but as far as the patient is concerned, it is an extremely distressful situation. What you need to have is extreme compassion for your patient. Please remember this take-home message. We end the introduction to the psychiatry at this point, and we'll meet and we'll continue to discuss various psychiatric disorders on further presentation. I hope you liked it. Thank you very much.